Welcome to the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery webinar series. Today's program on basic pharmacology of commonly misused prescription drugs will be presented by Dr. Lane Wallace. Thank you for joining us. My name is Ken Hale, and I am the Associate Director in the Higher Education Center, focusing on prescription drug misuse prevention. Before I introduce Dr. Wallace, I'd like to go over a few technical points relating to this webinar and provide an overview of the Higher Education Center. Our webinar provides a chat function which can be accessed by clicking the chat icon that looks like a cartoon word bubble, selecting all participants, and clicking send once your message has been entered. We will conduct a question and answer session at the end of the webinar. Please forward your questions using the Q&A function, that is the question mark icon, to the webinar host by clicking send. We will also have a few polling questions throughout the webinar, and I will give you instructions on that one along the way. The Higher Education Center is here to help colleges and universities develop, implement, and evaluation programs and policies to reduce problems experienced by students due to alcohol and other drug misuse. The center was reestablished at The Ohio State University in 2014 thanks to a generous grant from the Conrad Hilton Foundation. We are interdisciplinary in nature with strong partnerships between the College of Pharmacy, College of Social Work, Office of Student Life, the Generation RX Initiative, and Ohio State's collegiate recovery community. The Higher Education Center strives to contribute to student success nationally by providing a number of services to colleges and universities, including technical assistance, technology development, education and training, and research and development. We are here to provide information and resources, help facilitate the use of research and practice, drive innovations in prevention and recovery technology, and provide training and assistance to our member institutions. As you can see, our mission will be accomplished by data-driven solutions to alcohol and drug misuse, and with your help, we aspire to lead the dialogue on collegiate alcohol and drug misuse and recovery in the national agenda. You can stay connected with the Higher Education Center through email, social media, and via our website at hecaod.osu.edu. It is now my great pleasure to introduce Dr. Lane Wallace. Dr. Wallace is a professor and former chair of the Division of Pharmacology within the College of Pharmacy at The Ohio State University. His scholarly interests include neuropharmacology, mechanisms of action for addicting drugs, computational neurobiology of dopamine signaling, and neurodegenerative diseases. He received his PhD in pharmacology at the University of Utah before joining Ohio State's faculty. I have had the great pleasure of working with Lane for many years. He is a wonderful colleague and a wonderful teacher, having been recognized by our students with multiple teaching awards. And the information he is about to share will provide a critical foundation for better understanding one of our most serious public health issues, the misuse of prescription medications. A text summarizing Dr. Wallace's presentation will be posted to the Higher Education Center's website. Dr. Wallace, thank you so much for presenting today. I will now turn the program over to you.
Thank you, Ken. I am delighted to be here and to present this webinar on the basic pharmacology of commonly misused prescription drugs. I will begin by taking the three components that are found in the title and doing them in reverse order from how they are found in the title. Prescription drugs can be characterized by four properties I have listed on this slide. The first is that they are obtained by a visit to a physician, where the physician will do an analysis of the person and determine an appropriate therapeutic strategy. The patient then receives a prescription or a license to use the drug. For prescription drugs, the Food and Drug Administration has done a rigorous analysis of their effectiveness. Massive clinical trials are done, and the drugs are approved by the Food and Drug Administration for particular specific uses. There's a quality control maintained over all of the process of production and distribution of prescription drugs. This guarantees safety. This guarantees that what is in the bottle is actually what says is on the bottle and gives us a measure of confidence about what we are doing. The final parameter here is important. These drugs have some risk associated with their use, but it is very manageable. And it is important to realize with dealing with these drugs, there is no such thing as no risk. There's always some small manner of risk. And the key here is it is readily manageable. Misuse is defined as drugs that are taken for a purpose other than that for which the prescription was written, or a drug taken by a person other than the person for whom the prescription was written. There are some potential dangers of misuse. Again, coming back to the principle that no drug is without some minor manageable risk. These potential dangers are overdose problems, which result in emergency room visits and sometimes in death, addiction liability, and what I call a Generation RX culture. This chart from data published by the Center for Disease Control indicates the number of deaths, overdose deaths from misuse of prescription drugs as a function of years over the last 13 years or so. And you can see that during the early part of the 2000s, there was a steady increase in the number of deaths, which the last couple of years has plateaued and remained steady somewhere at a little over 20,000 people. So as a perspective, 20 to 25,000 people would be equivalent to the population of the student population of a medium-sized university. The second potential danger from misuse is addiction. So addiction is defined as a compulsion to use drugs, to use them in doses bigger usually than what is intended, and a loss of control over the amount of drug use. People with characteristics of addiction will continue to use the drug in spite of adverse consequences. The extreme on this is those smokers who have recently had part of their throat removed because of cancers caused by smoking, and then will stick a cigarette in the scar that's left, the hole that's left, in order to continue using their drug. When I say addiction, the drugs we're talking about have an addiction liability. I like the word liability because addiction is not automatic. It occurs in a certain percentage of users, but there is a big percentage of users for whom addiction never seems to be a problem. And we will talk more about the reasons for that later on. The final danger, in my opinion, is what is called the Generation RX phenomenon. This is taken from the title of a book that was published a while ago relative to the increasing use of medicines of all kinds in our population. We as a society have developed to the point where many feel that there is a pill to solve all of life's ills. Medical practice cannot solve everything, all illnesses yet, and there are many non-pharmaceutical means of improving health. So in some cases, the development of more depending on pills is a bad thing for our society as a whole.
So now it's time for our first polling question. You will see the question from Dr. Wallace's slide on the right side of your screen. Your responses are completely anonymous, but once you click your answer, you cannot change it. So please hit submit to register your response and wait for the results to be shared. You have about 15 seconds to finish this question. Also, remember to submit your questions to our webinar host for the Q&A session at the conclusion of our program. Okay, so Dr. Wallace, the question being, do you feel that students frequently misuse prescription drugs in any of these ways? It looks like the bulk of our participants are going to respond with D, all of the above, by taking a drug for a purpose other than that for which it was written as a prescription, giving one of your prescription medications to someone else, or taking a drug prescribed for someone else. Is that any big surprise to you?
No, all of these reasons are, all of these factors are, all of these reasons are utilized by various people. There's no one that seems to predominate above another. Okay, I'm now going to move to the part of the presentation that deals with pharmacology. We define pharmacology as the interaction of chemicals, specifically drugs, with living biological systems. In order to think a little bit like a pharmacologist, we have to realize that our bodies are made up of chemicals. Sometimes it doesn't sound so nice and to think that we're just a big bag of chemicals. But for purposes of pharmacology, we are to a certain extent. And then the drugs that we take are chemicals and interact with chemicals in our body, and these interactions follow the principles of chemistry and biochemistry. Once a drug molecule gets in our body, it meanders around to various locations looking for some chemical with which it has an affinity. It's kind of like somebody going solo to a big dance and looking for a partner. And when the drug chemical finds somebody that a chemical with which it has an affinity, it's finding that certain somebody at the dance that you want to partner with. And the drug will then interact with that particular chemical in the body, which we will call a target or a receptor. So this target or receptor is often a protein, which is a very large molecule relative to the size of a drug, and is often the target for a hormone or neurotransmitter molecule. So the drug is really interacting with something that has a function inside the body to make sure hormones and neurotransmitters are working appropriately. Here's an example. A chemical called enkephalin is a neurotransmitter in our bodies. It interacts with a protein called a mu-opioid receptor. And if the situation is right for somebody who's a runner, they might experience runner's high. I must confess that I don't experience this, I just get tired. Now, morphine is a drug that interacts with the mu-opioid receptor and mimics the effect of enkephalin and produces some kind of high. So we call morphine an agonist drug. Morphine is a drug that's the chemical is not normally in the body. When we put it in the body, the morphine finds this mu-opioid receptor, interacts with it, and then mimics the effect of the normal neurotransmitter enkephalin. Another drug is called naloxone, and naloxone also is capable of interacting with the mu-opioid receptor. But when naloxone seeks out and finds this receptor target, nothing happens. So we call naloxone an antagonist because it's not doing anything by itself. But because the naloxone is physically attached to the receptor, there's no space for the normal enkephalin neurotransmitter to get to its target. So the naloxone is blocking the enkephalin. And we sometimes call antagonist drugs blockers because they get in the way of the normal neurotransmitter from doing its normal function. Now, agonists and antagonists have a role in the hospital emergency rooms. If I have taken too much morphine and I am breathing very slowly and shallowly and possibly going to die because I'm not breathing sufficiently strongly, the hospital personnel will inject me with naloxone. The naloxone molecules will then seek out the mu-opioid receptor, knock the morphine off, and that will reverse my respiratory depression and I will recover just fine. An important pharmacological principle is that many drugs fall into families or classes of drugs. A family or class of drugs is a set of drugs in which all members have similar effects. They have similar effects because they all have the same effect on the same target. So they might all be agonists at a mu-opioid receptor. The nice thing about this family of drugs is you can substitute any one for any other member of the family. We take advantage of this in medical practice by selecting a drug that has the appropriate duration of action for the particular illness we are treating. Or for people that might have impaired kidney function or impaired liver function, we would choose a drug that is in the same family but not acted upon by the liver or kidney. So there's a lot of advantage to having many members in a family of drugs. There's also a commercial advantage too, I must confess, in that if one company is making a lot of money selling a drug, another company can make another member of the family and try to market and compete and get into some of the monetary action.
Okay, so Dr. Wallace has just given a brief introduction to these drug classes. Our next polling question is going to delve a little bit deeper into this. So the next question deals with which of these drug classes are prone to misuse? Opioid pain medications, stimulants, and sedatives. Take about 15 seconds to respond to this. So we've determined through our previous polling questions that college students may be prone to misuse drugs in a variety of ways. Now we're going to see what you think about which categories or classes of drugs are they prone to misuse. So Dr. Wallace, we have our results. I introduced you by way of saying that you were a fabulous teacher. And I'm going to guess that the test questions you give are a lot harder than these first two polling questions. But we have a pretty savvy audience on board, and they're saying the vast majority of our respondents saying that actually it's all of the above. Pain medications, stimulants, and sedatives are all prone to misuse. Is that correct?
That is correct. And as we go through the rest of this presentation, we will talk about opioid pain medications, and then stimulants, and then sedatives, so that we have some background on each of these drug classes. Before jumping into the drug classes, though, I have one more concept that is really important. Dose of drug is defined as the amount of drug that a person takes. I am often asked if a particular drug is safe, and my response will always indicate that depends on the dose. Appropriate amounts, as specified through the clinical trials sponsored by the Food and Drug Administration, are almost always safe, but higher doses may not be. This leads us to the concept that the spectrum of effects experienced by a person is a function of the dose of drugs. So, for an opioid pain reliever that we're going to talk about in a minute, relief of pain is the primary effect observed at the standard medical dose. And the respiratory depression that shows up that's the reason why people go to emergency rooms, doesn't show up at that dose, but shows up at a higher dose. And then sometimes the intensity of a particular effect experienced is a function of the dose. So a low dose might moderate or ameliorate a certain amount of pain, but it might take a bigger dose to ameliorate a stronger, more intense pain. I'm now going to talk about the opioid drugs, but before doing that, I am going to talk about homeostatic systems. A good example of a homeostatic system is the temperature in a building. And as illustrated in this picture, there are several components to a homeostatic system. One is a detector that measures the parameter that we want to keep within a certain set of limits. For our building temperature, around 72 degrees Fahrenheit. Some people like it a little bit warmer, some a little cooler, but approximately in that range. The thermostat measures the temperature, and when the temperature drops below the desired range, the thermostat closes an electrical circuit and turns on the furnace, which then produces heat and warms up the building. When the thermostat registers that the building has warmed up to the appropriate temperature, it turns off the furnace. And this process is repeated to maintain a very narrow set range of conditions. With air conditioning, the converse happens. As the temperature rises, the thermostat turns on the air conditioner. When the temperature falls back to the appropriate desired range, then the thermostat turns off the air conditioner. Pain is a homeostatic mechanism that is important for our well-being. Pain often tells us that we have experienced an injury and that we need to do something to care for that and to make us well again. Pain also is really important for helping us learn behaviors to prevent injury. The extreme example is people who are born without an ability to detect pain. If such a person puts his hand on a hot stove, the fingers burn because there's no signal to tell them to remove the hand. As such people usually do not live long, but if they do, they do not thrive very well. Simple things like learning how to eat become a very difficult problem. As we get teeth as an infant and start to chew, we occasionally bite our tongue, and the feedback from that pain teaches our muscles in our tongue how to keep the tongue out of the way of our teeth. If one can't feel pain, they never learn how to keep the tongue out of the way of the teeth, and they keep trying to eat their tongue as they eat their meal, which is not a very thriving condition. Another concept about the homeostatic system of pain is that it does not get maintained within a narrow set of limits all of the time. A good example is somebody is in the jungle and attacked by a tiger and mauled by the tiger. There are injuries that need to be attended to, but that is not the number one priority for the person at that time. Number one priority is escape from the tiger. So the pain system modulates down so the person doesn't feel the pain until they escape from the tiger, at which time the pain system modulates back up and the person recognizes the pain and takes care of it. This results in the fact that the pain homeostatic system varies markedly within an individual from one time to another, depending on the circumstances. It also means that there's a wide variety between individuals in the set points of the pain system. So some people have a high pain tolerance and others do not. Our pain homeostatic system has detectors in our tissues, like our fingers, that identify or become active when pain occurs. And the sensitivity is modifiable, so it can be very sensitive at some times and not so sensitive at others. In the spinal cord, there is a level of integration. The information after the pain is detected in the fingers, there's information sent by nerves to the spinal cord, and there's some level of integration there. Sometimes the integration is really fast. A spinal reflex will cause us to remove our finger from the burning stove before our brain even knows about it. Signals are also sent to the brain where there is an integration response and where there's an interpretation and where the learning and memory part happens. The target for the mu-opioid pain, for opioid pain relieving drugs is called the mu-opioid receptor. Obviously, named was discovered by trying to figure out how these drugs work. The drawing here has a picture of a mu-opioid receptor. The ribbons are chains of amino acids in a protein. The one on the left would be looking at this from the level of the plasma membrane, with the top part sticking out of the cell and the bottom part inside of the cell. And the green and red balls would represent a opioid antagonist drug. On the right, on the top, is a picture looking from the outside of the cell in, and on the bottom is a picture looking from inside of the cell out. So it gives you an idea of how big the target receptor protein is compared to the small size of the drug, and gives you an idea that these targets here, these receptors, are transmitting signals across cell membranes. So where are these located in the whole pain homeostatic mechanism? There is a cluster of these mu-opioid receptors in the spinal cord that is involved in the initial processing and in the sending of the signals into the brain. When the mu-opioid receptor is activated by the normal enkephalin neurotransmitter, that lessens the amount of pain signal that gets sent to the brain. Up towards the top in the area identified as PAG, or periaqueductal gray region of the brain, there's a cluster of mu-opioid receptors that are involved in the interpretation of pain signals. And these receptors are activated by the normal neurotransmitter enkephalin. We don't feel the pain as intensely. It doesn't bother us as much. These receptors also are involved in the interpretation of stress. And when the enkephalin is activating the mu-opioid receptor, stress doesn't bother us as much. So there's a dual function here in minimizing the impact of both stress and pain. We have a number of drugs that are agonists at mu-opioid receptors. So these are drugs that interact with the mu-opioid receptor in the same fashion as the neurotransmitter enkephalin and attenuate pain signals and alter the interpretation of pain so that it doesn't bother us so much. And I just listed a few of the names and some of the pictures of the medicines. There are many more. The major therapeutic use for opioid drugs is for treating pain. And an interesting phenomenon is that in the United States, a little more than half of the adult population has chronic pain at some point, as defined by pain that persists for more than a week and is not identified with a particular injury, such as a sprained ankle. So this slide indicates that out of the 320 million people in the United States, around 100 million have chronic pain at some point, which includes headache, low back pain, cancer pain, arthritis pain, and others. And of that, about 5 to 8 million are treated chronically with opioid drugs, or about 2% of the total population. I should mention here that while these drugs are wonderful at alleviating pain, they do not control all types of pain. So there are some kinds of pain that cannot be treated well by the opioid drugs. This graph indicates that prescriptions for opioid drugs have increased substantially over the last 20 years. This is not because the incidence of pain has increased, but rather our customs, our strategies for treating it have changed. So what has accounted for this increase in opioid prescriptions? Well, number one is that 25 years ago, there was a substantial fear of addiction from using opioid drugs to treat pain. And gradually the medical community accepted that everyone who got an opioid drug would not addict, that the number who would addict would be a small percentage, and that being more aggressive with treating pain would be not as problematic relative to addiction as at one time was thought. A second reason is the medical community decided that maybe we should be treating pain with a pharmacological strategy that rather than just saying, that's life, tough it out. And the third is our culture as a whole is more likely to want a pill for everything now than it was 25 to 30 years ago. A principle from this is that a certain percentage of people who use the drug will end up showing addiction properties, which we will talk about later. And there's going to be a certain amount of misuse. So the more prescriptions that are out there, the bigger the number of people that will suffer from an addiction problem or who will be involved with misusing the drugs in some way or another.
Okay, so it's time for our third polling question, and we're starting to see a bit of a theme here, Lane. Dr. Wallace is giving us the science behind the misuse of prescription drugs, and we're looking at some of the student behaviors to these polling questions. So we've talked already about kind of our perceptions of misuse. We've talked about the classes of drugs which tend to be misused, and now this question asks us our perception of the reasons the students would give for misusing prescription drugs. A, self-medication for pain or anxiety, etc. B, curiosity. C, seeking a mental feeling or state. Or D, all of the above. You have about 15 seconds to record your responses. And again, remember to submit your questions for our webinar host for the Q&A session that will be conducted at the conclusion of this webinar. So Dr. Wallace, I think our students are all getting A's in class so far. We see again, the vast majority are saying that really all of the above kinds of reasons are expressed by students sometimes for their misuse. Are you agreeing with that?
I am agreeing with this, and I am delighted when all of my students get A's. I wish that would happen in all of my classes. For people who take the drug as out of just curiosity, or for people who are seeking a particular mental feeling or state because others, friends or neighbors or internet sites or something has told them that this would be something desirable. There's some interesting studies relative to these concepts. In controlled laboratory settings, when people are given an opioid drug, not for pain, just take the drug and let's see what kind of feeling ensues. Now, why would you do that? Well, these drugs are altering perception of pain and of stress. Well, that means there's going to be some alteration of just how we're interpreting what's going on in our life right now as well. So in controlled laboratory conditions, people are given one of these drugs and asked, how do you feel about it? Does it feel good? Does it feel bad? Are you neutral? In this kind of setting, about 25% will say, I don't like this, which is interesting. I actually know people who would rather suffer through pain rather than take an opioid pain reliever because they don't like the mental state. There's 15% or so that are about neutral, no impact, and then about 60% who feel good. They like the feeling. And amongst that, there's various intensities of how good they feel. There's a very small percent who, when they take these drugs, say, wow, that's the best I have ever felt in my life. This is marvelous. I want this again and again and again. So there's that huge spectrum, individual variability from don't like to it's the greatest thing that ever happened in the world. All right, my cursor's sticking a little bit here. People who like the feeling and start misusing the drugs, that is, it's not the prescription's not written for them, they're not taking this for a reason for which a prescription was written, often show a preference for higher doses of drug. They want doses higher than that that has the standard pain relieving effect. The other thing these people discover is they have a preference for a faster onset of drug effect. This happens to be true for every drug that has addiction liability, all classes of drugs with addiction liability. The faster a person goes from no drug in the brain to high amounts of drug in the brain, the more intense and the better liked is the experience for those people who enjoy those effects of the drug. So this drives people to want to inject the drug, to snort it, that puts the powder or some kind of solid form in the nasal passages, or to smoke. This is a picture of an extended release tablet for oxycodone, an opioid pain relieving drug. The concept of extended release is that when this tablet is swallowed, the outer coating dissolves fairly rapidly to provide a certain amount of drug in my bloodstream and hence into my brain right away. And then after a half an hour, the next layer of coating will start to dissolve. And then after another half an hour, the next layer, and so forth over a several hour period. The reason for making such a compound is that we tend to be more reliable take our pain medication when it's once a day than if it's 3 or 4 times a day, and it's much more convenient. But if I'm a person who is misusing drugs and opioids now and I want to have a high dose effect, I can take this sustained release and I can pulverize it and I can dissolve it into water and extract out the drug. And now I have a high dose that's going to be really big right away. Or I can take that drug that I've dissolved in water and put it in a syringe and inject it. It's the same kind of principle with these time release capsules, where the capsule has a lot of little beady capsules inside, some of which dissolve really fast to provide opioid drug right away. Others of those smaller capsules dissolve half an hour down the road, and then another half an hour down the road. Again, it's a sustained release to give us a drug effect over a period of time. But if I really like high doses of drug, or if I want to inject drug, I can take these capsules and take them apart, and I can try to pulverize the plastic and extract the drug out and get me a high dose of drug. We now have a little bit of a game going on between the drug manufacturers and the drug misusers. Destroying these kinds of capsules became relatively common a few years ago. So the drug manufacturer has altered their sustained release capsules, time release capsules, and they have other kinds of products now that form in soluble gels and do other things to make the product unusable if you tamper with it. And we'll see how long it takes the inventive misusers to try to be able to successfully defeat that particular mechanism. We can move off from campuses and look at the general population of the United States and say, how big a problem is the misuse of opioids? We earlier identified 20 to 25,000 people die from overdose from prescription drugs, misuse of prescription drugs every year. About 15,000 of that is opioid users. And this gives us a number for about 2% of the population over 12 years old, or about 5 million people have misused opioids in the last month, and that has been relatively stable over the last few years.
So it's time for our next polling question, and we're looking still at student behaviors. Where do students most frequently obtain prescription medications for misuse? And this time there's no all of the above. Well, now we're going to really have to dig into this a little bit. A is the internet, B is a drug dealer, C is multiple physicians, or D, a family member or friend. Take about 15 minutes and remember to keep those questions coming in for the Q&A at our conclusion. Well, Dr. Wallace, I think we all know that students or anyone can get these substances from a variety of sources, probably all of the above in some percentage, but it looks like the majority of our audience again chooses D, from family members or friends. What do you think?
Our audience is really smart. This graph shows some information from a recent national survey that shows that more than 50% of non-medical opioids come from a friend or relative, and then another 15% are purchased or stolen from a friend or relative. And then about 20% come from one doctor where the person went into the doctor and would claim to want the opioid for pain when they didn't really have pain and intended to use the opioid for another purpose. So an interesting question is, of all these opioids that people are getting from friends and relatives, where do the friends and relatives get them from? And the vast majority is from a single doctor. Well, how has this happened? I'm going to tell you a story. As a late teenage young adult, I had plenty of space in my mouth for my wisdom teeth, so they were not removed at that point in time. And as I got to be about 50 years old, the wisdom teeth were kind of falling apart, so we decided it was time to take them out. When I went to the oral surgeon for the preliminary checkup, he gave me a prescription, asked me to have it filled before I had the surgery. I didn't look very carefully at the prescription. I went and got it filled and was rather surprised when I walked out of the pharmacy with a fairly large bottle with several hundred drug tablets in it of an opioid analgesic. Well, it turns out I have a fairly high tolerance for pain, and I ended up taking absolutely none of those pills. So now I have in my medicine cabinet a bottle with a couple of hundred opioid analgesic drugs, pain relieving drugs. What do I do with them? Well, sometime down the road, somebody in my family has some kind of pain condition that lasts a week or so, and we think about, oh, we have opioid analgesic drugs in the medicine cabinet. Should we just go ahead and have this person take one? Or maybe if I had an inquisitive teenager in the house, they might have just taken a pill or two. I never would have known the difference. So a lot of these opioids that are handed out for free end up being leftovers from situations like mine, which is why at the current time we're looking, or the medical community is looking very carefully at how many are getting prescribed and why, and trying to better match the pain needs with the amount that is dispensed. Doctor shopping that we hear about a lot is a person going from one physician to another trying to score opioid prescriptions. Recent survey indicates that that accounts for about 2% of the total opioid prescriptions, that about 1 out of every 143 patients actually goes doctor shopping. Those who do are really successful. 32 opioid prescriptions per person per year from 10 different prescribers. I just think about that. That's a different doctor every month, some of them more than once a month, and I'm getting an average of 3 different prescriptions from each one. I'm not sure I'm that good an actor, but some people clearly are. If we go beyond the simple misuse and ask how many are dependent or addicted to abuse of pain relievers, we get a number of about 1 million people in the United States currently. And finally, death from opioid overdoses occurs from respiratory depression. But if I'm taking a pain relieving dose of an opioid, I would have to take, and that's one pill, I would have to take somewhere around 50 pills in order to actually die from the opioid overdose. That's hard to do. So what's happening here? Well, people are taking higher doses rather than the analgesic dose, which puts you closer to the lethal effect. But more common is combining drugs with things that might not be considered dangerous, like alcohol or the anti-anxiety drug and tranquilizers, all of which inhibit breathing. And when you put a little bit of inhibition breathing from one agent and more inhibition breathing from another agent and more from a third agent, now you get into a dangerous situation. The other problem is switching drugs. And if I get a drug in the same family that works at a lower dose, I may mistakenly use the same amount that I've been accustomed to and overdose because I failed to account for the difference in potency. Okay, that finishes the unit on opioids. So we're going to move on to stimulant drugs now, drugs like Adderall, Ritalin, Vyvanse. And these drugs at the lower doses produce a mild elevation in mood, a feeling of self-confidence. They lessen fatigue, decrease appetite, increase the ability to focus by lessening the power of distractors, increase heart rate and blood pressure. Interesting studies done many years ago indicate that people who work in very repetitive, dull, monotonous jobs will continue to perform their job for a longer period of time with fewer mistakes if they have a low dose of stimulant drug in them. These drugs are primarily used to treat attention deficit hyperactivity disorder. It seems paradoxical that a drug that causes hyperactivity, at least at higher doses, can be used to treat a condition that is characterized by hyperactivity. The reason why we don't know, we don't understand the pathology of the disease. What we do know is in rigorously conducted clinical trials, these drugs are highly effective at treating ADHD. The target for these drugs is a protein called the dopamine transporter. The drugs inhibit the dopamine transporter. Dopamine is a neurotransmitter in the brain, and we can think of the dopamine transporter as being the drain for the dopamine. So the dopamine is put into the signaling space and then removed through its drain, the dopamine transporter. If you block the drain in your bathroom sink, the water level rises. If you block the drain for dopamine, the dopamine level rises. So these drugs increase dopamine signaling in the brain. Dopamine signaling occurs when the current situation is unexpected and important and mobilizes the brain for learning. Many of you have probably heard about the dopamine system being the reward system. The dopamine system is a component of the reward system, but not the entire reward system. But you can see how a increasing activity in a system that mobilizes the brain for learning in the presence of a drug that causes a feeling of self-confidence and well-being would be reinforcing and make the person want to use the drug again. Misuse on college campus is primarily used because the drugs have a reputation for being able to enhance learning and memory. And so a number of college students will take the drugs to help them in their quest for better grades. Surveys indicate that this is more likely to happen at campuses that are very prestigious, where grade point matters a whole lot, but it happens everywhere.
So here's our last polling question, and again, student behavior sort of question. What do we know about the misuse of prescription stimulants among college students? Is this behavior on a downward trend? Do students misuse these medications and then end up with higher grade point averages? C, do students have inflated perceptions of the misuse of these substances by others, or the ever tempting choice of all of the above? Take about 15 seconds. So Lane, again, the bulk of our class, this is a pretty savvy class we have in front of us, have chosen selection C, that students seem to have an inflated perception of the use of these by other students. This is an interesting question because one of the myths that we feel like we need to bust in this work is this myth of these drugs being study aids in terms of students actually getting better grades when they do use them. But let me let you respond to the results of that polling question.
Again, that is true. The students seem to have inflated perceptions. And there are some studies that have been done as to the efficacy of these drugs for learning and memory. The drugs do increase confidence, which can be a big factor. The drugs do lessen fatigue for somebody who has to stay up late and cram. On the other hand, sleep is absolutely required for the formation of long-term memory. So staying up late and cramming impairs or it interferes with sleep and interferes with the ability to form long-term memories. And the studies consistently show that use of stimulant drugs narrows the choices that people consider when they're dealing with complex problems. So if the nature of the learning activity involves an analysis of a lot of different kinds of information, performance is actually inhibited or lessened by the use of stimulant drugs. Relative to stimulant drugs, this shows us that about 1.2 million people in the United States misuse stimulants in the last month. So that goes off from campuses and covers the entire United States. Our final class of drugs is anti-anxiety agents, of which the benzodiazepine family is the most common. Benzodiazepine is a chemical term, and these drugs all have a similar internal chemical structure. And names like Valium and Librium and Xanax are familiar to many of us. These drugs are part of a big depressant family of drugs, which with increasing dose marches through relief from anxiety, sedation, sleep, general anesthesia, coma, and eventually death. The drugs have their major use to treat anxiety, but they are also used as sleep aids to treat panic attacks, preoperative sedatives, anesthetics, treatment of epilepsy, and muscle relaxants. So they're widely used in our population. The drugs impair short-term memory, which sometimes might be adverse, like if I'm anxious about my exam tomorrow and I take the drug to try to control the stress, then I'm not going to learn the materials well. But on the other hand, if I'm going to have my colonoscopy and I get one of these drugs that impairs formation of memory, I'm going to appreciate that. The drugs have, again, potential for dependence and addiction. Their target is a protein called GABA, or is a receptor for the neurotransmitter called GABA. See a nice picture there of a GABA receptor. In the brain, there are two controllers for most activities, one that is excitatory and one that is inhibitory. It's like having the accelerator or gas pedal in your car and the brake. One increases your speed, the other slows you down. GABA is the major brake in the brain. major neurotransmitter on the inhibitory side. And these anti-anxiety drugs all make GABA work harder, work more powerfully. So you can see as higher doses, you are potentiating the inhibitory ability of the brain and shutting everything down. These drugs are primarily misused because people are using them to manage anxiety in the absence of a medical personnel supervision. And they see the incidence here of about 2.5 million people currently, or last month, have misused. And since those are probably less used on campus, we won't spend more time on them. In the few minutes remaining, I'm going to make a couple of comments relative to addiction, which is one of the adverse effects of misuse of drugs. About 50% of the liability is genetic. Oh, I should mention that across all the spectrum of all drugs that have addiction liability, about 15% of people who regularly use will show addiction properties in that they lose control, and about 15% lose control, about 85% do not. So the question is, what's unique about that 15% that run into trouble? About 50% of that is genetics. A big fact component is stress. A major liability factor is childhood abuse. And then about 50% of those who develop addiction have some kind of other mental illness, such as depression, obsessive compulsive disorder, or manic depressive. And finally, the motive for using drugs turns out to be really important. Am I using the drug to seek a particular feeling, or am I using the drug to alleviate my pain? So to summarize, the opioids, stimulants, anti-anxiety drugs are all commonly used therapeutic agents. They have a well-established role in medicine. A small percentage of medical users will develop addiction. With the opioids, it tends to be a little less than 10%. Some of the other drugs a little higher. A certain percent of prescriptions get diverted and provide misuse. People who misuse drugs regularly often prefer higher doses and a faster onset of action, and they will manipulate the sustained release preparations to be able to find a way to get their higher dose. Death from overdose often involves combinations of drugs or switching from a standard dose or from one agent to a more potent form. And then the liability of addiction is about 50% genetics, substantial stressful life experiences, and motivation for using drugs.
So our time is just about over, but I do have one question for you, Dr. Wallace, and then before we conclude our webinar. Let me pose this to you. Drug misuse is certainly not a new issue in our society, but do you see anything about the current misuse of prescription medications that is perhaps different than what we have experienced around substance misuse historically? It might give us some clues about prevention strategies for this phenomenon.
The most interesting thing I see in the historical perspective is the ebb and flow of particular kinds of drugs that are misused. So the total amount of misuse doesn't seem to change a whole lot. It seems to be a constant percentage of the amount of drug used in regular medical practice. But for example, I started college in the early 1970s. And at that point in time, the barbiturate drugs were the most common misused drugs on campus. And students in my classes today don't even know what barbiturate drugs are. So what gets misused seems to change, and it seems to be fueled in some extent by the response of the press and free advertising, so to speak. This is what is currently available. This is what's happening, which engenders a certain amount of curiosity. And part of that is sensationalism, where something new comes up, and rather than realizing this happened previously, it's made out to be something new and novel. So maybe part of it is just understanding that this always happens and trying to manage things better.
It sounds like we're dealing with a moving target. Some of the underlying assumptions and causes and behaviors may be stable, but we're simply dealing with new and different challenging drugs, and we need to stay on top of that and stay on top of what our students are hearing and seeing in terms of marketing. So I want to thank you, Lane, very much for helping us better understand the mechanisms of action for commonly misused prescription drugs. I really want to thank all of you for joining us in this webinar today. Please keep in touch with the Higher Education Center via email, social media, or through our website, and have a great week.